This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Epilepsia Open, published in 2026, titled Scalp Fast Oscillations Detected by High-Density EEG as a Non-Invasive Predictor of Surgical Outcome in Temporal Lobe Epilepsy with Hippocampal Sclerosis.
This is a timely paper, Alara. For those of us in the OR, temporal lobe epilepsy with hippocampal sclerosis, or TLE-HS, is one of the most common indications for surgical intervention. We know that anterior temporal lobectomy, or ATL, can be life-changing, but our ability to predict exactly who will achieve seizure freedom remains an area where we need more precision.
Exactly. Traditionally, we've looked at the gold standard of invasive monitoring to find high-frequency oscillations, but this study explores a much less invasive route. They specifically focused on scalp fast oscillations, which they've abbreviated as SFOs.
And just to clarify for our residents listening, when the authors say fast oscillations in this context, they are defining them as frequencies greater than 30 Hz. Alara, walk us through the technology they use to capture these signals on the scalp. It's not your standard 1020 EEG setup, is it?
Not at all. The researchers utilized 256-channel high-density EEG, or HD-EEG. The core objective was to evaluate whether these scalp oscillatory patterns could serve as a non-invasive predictor of surgical outcomes for these drug-resistant TLE-HS patients undergoing ATL.
This is where the physics of neurosurgery meets clinical practice. Detecting anything over 30 Hz on the scalp is notoriously difficult because of the filtering properties of the skull and the low amplitude of those signals. Using 256 channels provides the spatial resolution necessary to potentially isolate those SFOs. Why is this significant for our surgical planning?
Well, the study suggests that the presence and characteristics of these SFOs are associated with surgical outcomes. If we can identify these markers before the patient ever goes under the knife for an ATL, we have a biological indicator of the epileptogenic zone that doesn't require drilling burr holes for intracranial electrodes.
Let's dive deeper into the patient cohort. These were patients with drug-resistant TLE-HS. That drug-resistant label is key. These are the patients who have failed at least 2 appropriately chosen and dosed anti-seizure medications and are now looking at surgery as their primary hope for a cure.
Right, and the study specifically looked at those undergoing anterior temporal lobectomy. By analyzing the 256-channel HD-EEG data, they were looking for a correlation between those preoperative scalp fast oscillations and the postoperative success, meaning did the SFOs correctly point to the success of the ATL?
It's an elegant concept. If the SFOs are localized to the area we are resecting, the predictive value for a good outcome should, in theory, be higher. The paper emphasizes that these SFOs are a non-invasive predictor. In the world of epilepsy surgery, non-invasive is the holy grail. If we can achieve high-density mapping without the risks of hemorrhage or infection associated with invasive grades or depth electrodes, we're moving the needle for patient safety.
And for the residents listening, it's important to note that they were looking specifically at hippocampal sclerosis. This is a very specific pathology. The study wasn't just looking at TLE in general, but at the classic HS subset, which gives the findings a lot more weight for that specific diagnostic group.
What I find most impactful is the focus on the greater than 30 Hz range. Historically, we focused on spikes and sharp waves, but those are relatively slow. By moving into the fast oscillation territory on the scalp, we're tapping into a different level of neurophysiological data.
Precisely. The abstract highlights that evaluating these patterns is a viable way to predict surgical outcomes. If the SFO patterns match the surgical site, we have a much higher confidence level in the ATL success.
It's about managing expectations as much as it is about refining the surgical target. If a patient's HD-EEG doesn't show these localized SFOs, we might need to be more cautious in our prognosis or reconsider if the ATL alone will be sufficient.
It definitely points toward a future where 256-channel HD-EEG becomes a standard part of the pre-surgical workup for TLE-HS.
Absolutely. It's a compelling argument for the integration of high-density electrophysiology in the clinical setting. Thank you, Alara, for breaking that down. For our listeners, keep an eye on those high-frequency bands. They might just be the key to better outcomes in the OR.
Thanks for having me, Dr. Aris. We'll see you all next time on the Neurosurgery Hub podcast.